good evening, everyone. I hope everyone is doing well. And yesterday was the World Asthma Day, and a very important day in the life of all pulmonologists. And this year, the theme was very important because every year, Gina has been stressing on anti-inflammatory reliever therapy because that's the way forward in the treatment of asthma. And since the last couple of years, the standard theme has always been, introduction of anti-inflammatory relievers globally. But unfortunately, it has not picked up in the developing world. So Gina decided to make this the theme of World Asthma Day this year so that people take it up globally. So now today is the right day to discuss a lot of new things about asthma. The new GINA guidelines have come yesterday. A few important changes have come in the GINA guidelines. And the way GINA and Gold function is that every year they collect important data, new data, and then they would kind of, change their guidelines. So you would see a lot of new, interesting, contemporary topics that have come up in the GINA guidelines this year. And all of this is based on the literature and the new material that comes in the last 1 year. So a lot of practice changing guidelines have gone into the management of asthma, the way we look at asthma. And a few important publications in the asthma space in the last couple of years is what we'll be talking about today. So the talk today would be by Dr. Avya Bansal, who's a senior pulmonologist based from Mumbai, and Avya would be talking about the recent changes in the new, a lot of new papers in asthma. And these are important papers that have led to guideline changes in GINA. This will be followed by a panel discussion. We have a stellar panel today with us. I'll be introducing them late as we start the panel discussion. But the first part of the program today would be on the important literature changes that have taken place in asthma. And this webinar is brought to all of you by courtesy of the Indian Chest Society. So I thank Chavla sir, Amita Nene ma'am, and Radha Munje ma'am for doing this every week and for bringing this important webinar to all the pulmonologists in the country. So Avya needs no introduction. Avya is a senior consultant pulmonologist. He works at Bombay Hospital and also is an honorary consultant at Mumbai Police Hospital. He's been a university topper throughout his undergraduate and postgraduate days. He has special interest in obstructive lung diseases, sleep apnea, and in adult vaccination. A dear friend and always a pleasure to interact with you, Avya. And all yours. Please go ahead.
Thank you so much, Arjun, for that warm introduction. At the onset, I'd like to thank the Indian Chess Society for giving me this opportunity and talking about asthma per se, and a very important topic which I would be speaking about. That's the recent practice changing publications over the last few years and how it has shaped asthma management in our practice. GINA guidelines came last evening. A lot of my talk will incorporate the changes which have happened in GINA. But also, like Arjun said, we need to remember that when evidence is generated, GINA only acts after that. So as pulmonologists, it is our duty to keep generating evidence so that future guidelines have and incorporate the correct way of treating patients. So first, let's look at the part one of my talk, which would be about redefining asthma management. So in asthma 2026, what has fundamentally changed? There's a massive advance in understanding the biology of asthma. There's a shift from symptom relief concept to risk reduction and disease modification. There's been a recognition of heterogeneity and treatable traits, emergence of precision-guided biologics, introduction of remission as a realistic and achievable goal when we speak of asthma. And asthma is no longer a one-size-fits-all airway disease or a one inhaler fits all airway disease. And we need to look at the broader concept in asthma management. Now, the change in asthma paradigm has been a tough one. It's taken pulmonologists like us years and years of hammering down things down everybody's throats and generating evidence and ensuring that the old way of diagnosis based on symptoms and variable airflow limitation, stepping up treatment mainly by symptoms, SABA being the cornerstone of relief, something we all dreaded for so many years, and severe asthma treated late, often after years of damage. Where symptoms were the primary cornerstone of treating the disease and the pathophysiology of asthma was always neglected. Generation data, which was generated by the overuse and misuse of SABA, finally brought a big shift. And the new asthma, like I would like to say, would be the asthma which is driven by a pathophysiological based treatment where it recognizes asthma as a chronic inflammatory disease with a future risk of exacerbations where biological failure takes place and not bad luck. The exacerbations are the inflammation taking away forward and causing the airway to shut down, and it's just not bad luck where exacerbations take place. Inflammation is present even in mild asthmatics, and they should not be neglected, which was proven by mild asthmatics performing the worst as compared to moderate or so-called severe asthmatics. And remembering the fact that asthma has airway remodeling and it begins early. So if not treated early on, airway remodeling can start and be permanent. The end of the SABA only era. For decades, asthma treatment began and ended with SABA for symptoms. ICS was an afterthought. It was added later on if symptoms persisted, yet exacerbations occurred even in mild asthma. And mortality paradoxically was higher in SABA users, 2 times greater risk in individuals using more than 3 canisters in a year, causing further exacerbations. And the central question remained for long is that was asthma frequency an adequate measure of asthma risk? The radical shift took place in 2021, where ICS formoterol reliever became the preferred track or track 1. And the Sigma 1 and the Sigma 2 studies made an impactful role in driving from a SABA to an ICS formoterol based treatment. This changed practice significantly because the concept of intermittent asthma was eliminated. The shift from early care, from symptom relief to prevention became important, and anti inflammatory therapy or AIR relief therapy from first prescription was important. And as of today, no asthmatic patient should leave with a SABA alone, and reliever choice is discussed as seriously as controller therapy. Let's talk of smart therapy, single maintenance and reliever therapy, one inhaler with 2 roles, a maintenance of a fixed dose ICS formoterol with the ICS being in a low dose once or twice daily. And the reliever is the same reliever which is used as a rescue, and no separate SABA is required. Every rescue dose delivers both the bronchodilation, which results as a result of inflammation. So you've got the anti-inflammatory part as well as the bronchodilator, and lower overall net ICS exposure than the conventional fixed dose titration therapy. This resulted in fewer severe exacerbations versus ICS plus SABA. GINA 25 preferred reliever for adolescents and asthma across steps. The NAP 2020 co-endorsed for steps 3 and 4 in US guidelines, and 6 to 11 years limited RC data was there. But now we'll be speaking about the CARE data which has been published, where this has changed even in 5 to 15 years. GINA 2026 has some updates where we talk of budesonide formoterol, but it continues to be the preferred treatment in adults and adolescents with asthma. AIR only, that's as needed. ICS formoterol therapy becomes the anti-inflammatory reliever therapy of choice in track 1. And in track 2, ICS SABA is the reliever choice over SABA alone. So the preferred track remains the low dose ICS formoterol, and the reliever is also low dose ICS formoterol. So for example, if you have a patient who's on step 4 treatment with a medium dose ICS formoterol, the rescue inhaler would be a low dose ICS formoterol in this individual. You've provided the patient is on track 1, which has to be the preferred track. And when we speak of track 2, SABA should not be the reliever of choice. ICS SABA in combination has to be the reliever of choice in track 2. Budesonide formoterol for children with asthma. The first randomized controlled trial of ICS formoterol versus SABA as reliever monotherapy in children aged 5 to 15 years with asthma in a real-world setting. And budesonide formoterol resulted in a lower rate of asthma attacks than salbutamol. This was a multi-center superiority randomized controlled trial. That's the CARE trial, and over 52 weeks, it proved that ICS formoterol combination was superior to SABA monotherapy even in children aged 5 to 15 years and resulted in lower rate of asthma attacks. Currently, that study is being carried forward for data for children between 2 years and 5 years, and hopefully by next year or by 2028, we will have data about the safety of ICS formoterol in children between 2 years and 5 years. As of now, 5 and 15, ICS formoterol versus SABA, ICS formoterol has a lower result of asthma attacks. So therefore, GINA 2026 now includes low-dose ICS formoterol as an anti-inflammatory reliever therapy, even in step 1 and 2 for children between 6 and 11 years. So GINA 2026 confirms we now need to start moving away from SABA alone therapy, even in children between 6 and 11 years. And as more data is generated, probably below 6 years, we'll have similar results in the days to come. The important question is, can budesonide formoterol be used even in an acute asthma exacerbation? So prospective RCTs were done, comparison of budesonide formoterol versus salbutamol, and comparable discharge rates of ICS formoterol versus salbutamol was formed, and similar improvements in the peak expiratory flow rate, respiratory rate, and oxygen saturation was achieved. Significantly lower IV steroid use in the ICS formoterol versus the salbutamol, and a lower impact on heart rate. So when the discharge rates were comparable in the ICS formoterol versus the salbutamol group, the lower steroid use and lower impact on heart rate was seen in the ICS formoterol. This suggests a positive impact on earlier anti-inflammatory use, and this was published in the Journal of Asthma in 2025. So the key question is that, should we also move beyond SABA in the emergency room itself and switch to an ICS formoterol based combination? The answer is yes. GINA 2026 acknowledges ICS formoterol as a potential option even in an acute care setting. A very busy slide, and I'm sure all of you all have read the 2026 GINA update and will continue to do so and use it as a referral point. But for me to summarize the acute care setting, the anti-inflammatory reliever concept is no longer limited to maintenance care, and it is now being explored and incorporated even in acute asthma management strategies. This is what we need to remember, that SABA is not the only inhaler or nebulizer of choice given in an acute setting, and ICS formoterol is the anti-inflammatory reliever which can be used and has better yielding results. Now, expanding bronchodilation with clinical intent, let's look at the triple therapy concept in asthma. So we've got recent data which was published in Lancet Medicine in 2026, where budesonide glycopyrronium formoterol combination, that's the Kalos on the Logos study, found superior lung function improvement by 76 ml as compared to formoterol budesonide alone, significant reduction in severe exacerbations, consistency and efficacy across studies, and acceptable and a balanced safety profile. So GINA 2026 report also included FBG as a treatment option for patients on medium to high dose of ICS LABA. That's step 4 and step 5. So the Kalos and the Logos studies published in Lancet tells us that the FBG combination should be used in patients with moderate to severe asthma or patients on medium to high dose inhaled corticosteroids and are still symptomatic, and switching them from formoterol budesonide or ICS formoterol to a triple therapy of FBG yielded superior results. Moving on, let's talk about redefining the treatment goals, which becomes so very important when we look at asthma management. The new goal of asthma management is remission. Now, we've all heard about remission in medicine across specialties. We've spoken about remission in cancer, we've spoken about remission in rheumatology. But what about remission in asthma management? What about remission in respiratory medicine? What does remission mean? Remission essentially incorporates 4 key points. That is no exacerbation, no OCS burst, emergency department visit, symptom control, that's the ACQ or ACT score within normal limits for 12 months, a stable lung function, and minimal or no medication. So you've got 2 aspects to remission. One is the clinical remission, where the patient is asymptomatic. One is a pathophysiological remission, where the reports of the patient, that is the inflammatory markers, the biomarkers, and the clinical status of the patient is asymptomatic. Followed by, you've got an off-treatment remission and an on-treatment remission. An on-treatment remission is a biological-driven remission, where the patient does not require drug withdrawal and does not require an add-on drug and does not see OCS bursts. This was explicitly seen in 2024 GINA protocol. And finally, when we talk of off-treatment remission, this is the natural history of asthma, more commonly seen in children, where we see that the lungs mature, develop, and a positive off-treatment remission was seen in children who are advised anti-inflammatory reliever therapy upfront as compared to SABA or salbutamol alone. So that is the whole concept of remission, and the key point of remission is to be stressed in each and every patient, because the first thing the patient will ask us is how long I need to use this inhaler. Is this something which is permanent? Is this going to be there with me lifelong? The answer is no. The answer is it depends on the patient itself, and the concept of remission needs to be touched on with each and every patient. Is remission an achievable goal? That's the important question. So the post-hoc analysis of CAPTAIN found that the remission in the FUV versus the FV group was significantly seen in a 24-week post-hoc analysis. Let's talk of biologics. What is the role of biologics in inducing remission in asthma? So we've seen data with three biologics, that's the Ig, anti-Ig therapy, anti-IL-5 and anti-IL-4 receptor agonists, and analysis of long-term use, that's 12-month data of biologics for severe asthma in clinical trials has shown that asthma remissions are achieved at a frequency of 20 to 35%. So yes, this becomes the on-treatment remission. Whenever a patient has been advised a biologic, the goal of the biologic or what we expect from the patient from the biologic has to be defined. This does not mean that the patient will be off treatment forever. This does not mean that the basic treatment may come down. This essentially tells us that the biologics will have a 20 to 35% success in reducing the OCS bursts, in providing symptomatic relief, in preventing further exacerbations, and in preventing add-on therapy. So that's the whole point of remission on treatment with biologics. Moving on to the treatable trait frameworks. This has finally caught up in asthma as well, where we speak about treatable traits. Now, why severity-based classification of asthma was inadequate? Asthma was often labeled as mild, moderate, or severe and did not explain the discordance between symptoms and inflammation, variable treatment responses among similarly severe patients, persistent exacerbations despite guideline escalation, increasing recognition in asthma that is a biologically heterogeneous disease driven by multi-morbidity and multiple coexisting pathological processes simultaneously, which finally described the severity and not the mechanisms. So the origin of the treatable kit concept was first proposed by a precision medicine model for chronic airway disease, where the core principle was to deconstruct asthma into an individual, clinically relevant, measurable, and a modifiable trait. So you treat the trait and not the diagnostic label. And it's applicable across severities, disease phenotypes, and care settings. So the deeper you dive into the nitty-gritty of the patient itself and understand the root cause of the asthma in the patient, the higher chance of achieving remission and minimum dose requirement for this patient. A very busy slide talking about the concept of triple therapy in achieving treatable traits as a prime objective, where we had the 5T approach in asthma, that was the triple therapy targeting treatable traits. Let's look at the fundamental aspect of each molecule. That's the ICS, ICS-LABA, and the ICS-LABA-LAMA. So the ICS essentially reduced exacerbations, eosinophilic inflammation, and small airway dysfunction. When you added LABA to it, it reduced the airflow limitation and mucus hypersecretion. And when you added LAMA to it, it reduced the neuronal plasticity and neutrophilic airway inflammation. So essentially, when you combined the ICS, LABA, and LAMA, you achieved reduced exacerbations, reduced airflow limitation, neuronal plasticity, reduced eosinophilic inflammation, small airway dysfunction, mucus hypersecretion, and neutrophilic inflammation. Which is why when you move from step 4 to step 5, a single inhaler triple therapy targeting the treatable trait becomes the way forward. And that's the concept of treatable traits in the era of triple therapy with respect to asthma. And that is what the Lagos study also proved when it was combined with FBG versus budesonide formoterol. A, B, C, D, E of asthma and the era of biologics as treatable traits. When we look at airway hyperresponsiveness, bronchitis, colonization with bacteria, damage to the airway resulting in small airway dysfunction, and extrapulmonary factors such as acid reflux, allergic rhinitis, smoking, obesity, laryngeal obstruction, breathing pattern disorder, and non-adherence or non-compliant. These were the cornerstones of the treatable traits with respect to asthma. And that is why each and every asthmatic should be assessed for each and every treatable trait before we advise therapy. What do you mean by the treatable trait approach? First and foremost, whenever the asthmatic patient comes to you, there is a clinical suspicion of asthma. Identifying the type of inflammation becomes extremely important, whether it is a T2 driven or a non-T2 driven, whether it is a corticosteroid exposure which responds, whether the patient has received corticosteroids systemically previously. Is there a cough hypersensitivity reflex? Is there medication non-adherence, suboptimal inhaler technique, tobacco exposure, inactivity and obesity? Whether there are extrapulmonary manifestations such as anxiety, osteoporosis, chronic rhinosinusitis with nasal polyposis, GORD or gastroesophageal reflux disease, and laryngeal obstruction. By just treating the patient with the ICS formoterol combination, when the treatable traits are not looked at, suboptimal achievement in the results would be there. That is why the concept of treatable traits and super traits when we look at asthma should be identified in each and every patient. Typically, airflow limitation, airway inflammation, allergic sensitization, adherence to therapy, inhaler technique, which is why teach back approach at every visit has to be monitored and supervised, physical inactivity, encouraging activity by allowing more than 7,500 steps to be the minimum target for every asthmatic, and smoking cessation becomes the cornerstone of treatable super traits in asthma. What is this new concept of treatable trait change in the clinical practice? So initially, a stepwise escalation was only based on symptoms, prolonged corticosteroid exposure, and a late referral for biologics. Now we look at early identification of dominant traits, biomarker-driven initiation, active management of extrapulmonary and behavioral drivers, and treatable trait frameworks embedded with routine asthma care. If GRD is present, smoking is present, obesity is present, no matter how the inhale corticosteroid, the symptoms, that is where patient holistic and identifying rather than moving on to step 4 and step 5. Moving on to precision therapy in asthma, about biologics and patient-specific care. Now, why biologics truly represent a paradigm shift when we speak of asthma? Severe asthmatics typically affects 5 to 10% of the asthma population. This group accounts for a disproportionate severe exacerbation, hospitalization, and OCS burst. And the reason for biologic and disease modifying therapy, which was initially kept at the last minute, steroid resistant asthmatics, multiple bursts of OCS, multiple exacerbations were the ones who were referred. Now, early identification of uncontrolled type 2 inflammation, biomarker guided therapy selection, OCS sparing as the central treatment goal is the way forward when we speak of biologics. How do biologics work? Let's talk of T2 inflammation when we speak of IL-4 and IL-13, which causes Ig production and mucus hypersecretion. Then you've got the good old IL-5, which causes eosinophil, which has been the cornerstone blamed cell in asthma, eosinophilic proliferation and survival. And finally, the alarmin concept, where the upstream alarmins, that's the TSLP, activates inflammation before the clinical phenotypes diverge. A very busy slide, but an equally important slide to understand the type and the pathophysiology of biologics and how they work. We've got the non-T2 and the T2 inflammation. You've got a T2 independent, paucigranulocytic, allergic, and eosinophilic. Finally, you come to the licensed targeted therapies of the TSLP, IG, IL-4, IL-13. And finally, you see that these are all the downstream cytokines which we talk of. The downstream cytokines are the IL-4, 5, 13, which attacks the Ig and the eosinophil. The bacteria, viruses, smoke causes destruction of the epithelium, stimulates an hyper response, and eventually causes stimulation of upstream cytokines, which eventually stimulate the dendritic cells, and this cascade follows. The concept is moving from the downstream cytokines to the upstream cytokines, that is targeting the precursor cell before the downstream cytokines are stimulated. And hence, more research is into IL-33 inhibitors, IL-6 inhibitors, and TSLP inhibitors in managing asthma. Looking at the overall approved biologics for asthma, you've got the omalizumab, which is anti-IL-5, mepolizumab, racilizumab, depemokimab, benralizumab, which are IL-5 inhibitors. You've got tezepelumab, which is the anti-TSLP inhibitor, and you've got dupilumab, which is the IL-4, IL-13 inhibitor. More data and more research is required for the upstream cytokines to act in management of asthma. Biomarkers drive the selection of biologics. What are the biomarkers to be done before you consider giving a patient a biologic is the exacerbation history, OCS dependence, FeNO or fraction of exhaled nitric oxide, which tells you the inflammation, blood eosinophil count, IgE, presence of comorbidities such as obstructive sleep apnea, gastroesophageal reflux disease, chronic rhinosinusitis with nasal polyposis, and depression. It's a very simple concept to understand T2 or non-T2 inflammation. If you elevated Ig levels, elevated eosinophil count, and elevated FeNO, all three biomarkers are high, it's a T2 inflammation. If all three biomarkers are normal or within low limits, it's a non-T2 inflammation. If you've got two biomarkers which are positive, it moves towards T2. If you have one biomarker which is positive, it moves non-T2. So that's the understanding of biomarkers before deciding the selection of biologics. GINA 2026 recommendations also for the same biologics follows the same. Adherence to therapy, technique of inhaler is mandatory for each and every patient before you escalate therapy. Ruling out multipomorbidities, comorbidities, and finally, biologically driven selection of biologic has to be advised, where your biomarkers of FeNO, IgE, eosinophil count drive and help in deciding the type of biologic which will work for the patient. Now let's talk about biologics in pediatric use. Earlier and broader and more nuanced use. There's a major shift from last resort biologics to earlier consideration in children with severe high risk asthma. Increased confidence in dupilumab, tezepelumab across wider phenotypes, where omalizumab remains the most favored, safe, long data achieved biologic in pediatric medicine. The biologics in children, the right drug, the right child becomes very important. So above 6 years for IG mediated, you've got omalizumab, which reduces exacerbation. The Messner-Muscat study showed that IL-5 inhibitor above the age of 6 years is T2 inflammation targeted in children. Bendra above 6 years again, dupilumab above 6 years, which targets IL-4, and tezepelumab, that is the anti-TSLP above 12 years of age, the Navigator study across all phenotypes. So T2 independent inflammation in an uncontrolled asthmatic above 12 years, tezepelumab can be considered. A little focus on dupilumab and the type 2 airway disease concept. Particularly, dupilumab should be positioned in patients with high pheno, with asthma and chronic rhinosinusitis with nasal polyposis or other atopic diseases, incomplete response to anti-IL-5 strategies, less dependent on eosinophil counts alone, and biologic of choice where extrapulmonary T2 inflammation drives the morbidity. So it's a one biologic with a multi-organ benefit when we look at dupilumab and T2 airway disease concept. Let's look at some of the non-asthma indications of biologics. When we look at omalizumab, IG-mediated food allergy, chronic rhinosinusitis with nasal polyposis, urticaria. Mepolizumab is used for chronic rhinosinusitis with nasal polyposis, COPD recently approved, EGP and hypereosinophilic syndrome. Depemokimab, which is once every 26 weeks, approved above the age of 18 years. Racilizumab and benralizumab for EGA. Looking at dupilumab for moderate to severe atopic dermatitis, chronic spontaneous urticaria, COPD, eosinophilic esophagitis, and chronic rhinosinusitis with nasal polyposis, and tezepelumab for chronic rhinosinusitis with nasal polyposis. Tezepelumab, the phenotype agnostic biologic, has a 74% reduction in the annual exacerbation rate to Navigator data in 2021, 62% reduction in severe exacerbations requiring OCS, and 43 to 83% reduction in biomarker subgroups in low eosinophilic non-allergic asthma. No biomarker prerequisite was required for tezepelumab to be the asthmatic biologic of choice in children above 12 years of age. So if there is doubt, no biologic data needs to be assessed, and tezepelumab was the safe and the most favored biologic in the Horizon trial. Current data with 5 to 12 years and safety of tezepelumab is currently ongoing. And finally, preschool wheeze and prevention of asthma. Can we prevent asthma? The ERS 2024 statement in May updated the phenotypes as episodic, viral, or multi-trigger wheeze, where the continuous or intermittent ICS both reduce the recurrence. Using azithromycin upper respiratory tract infection reduced the risk of developing asthma. No benefit of azithromycin was seen in emergency department presentations, and the RSV asthma pathway, RSV during bronchiolitis exacerbations, resulted in a preschool wheeze, and azithromycin probably prevented that, and early research is going on. Recurrent infections with type C rhinovirus also results in asthma in children, and therefore prevention with rhinovirus is underway, and more data regarding vaccination for the same has been explored. The other changes in GINA 2026, that's new tools for assessment of patients with asthma. You've got the CAAT or chronic airway assessment test, the pediatric asthma impairment and risk questionnaire, and the PRAM, that's the pediatric respiratory assessment measure. Vaccination update on influenza, RSV, and COVID-19 has been there. Pneumococcal consideration has been included. And brief update on obesity being a risk factor and driving uncontrolled asthma, and the future role of GLP-1 has been touched upon. What changes tomorrow? The remission, reframe the conversation, discuss remission at the onset and not just control status. Talk about biologics, look at the biomarker in the patient. Single maintenance and reliever therapy, switch eligible patients above 12 years of age from SABA-based regimen to ICS formoterol single inhaler. Adopt at diagnosis pheno for every biologic initiation. It helps in understanding the T2 inflammation and adherence, and azithromycin to be used in upper respiratory tract infection to prevent a preschool wheeze. 5 things to carry back to the clinic from today's talk is that remission and not just control is the new goal, and that's the way we must look at all our asthmatics. Match the biologic to the biomarker. identify the treatable trait and the biomarkers at the onset of diagnosis or the first visit of your asthma patient, replace the SABA with the ICS formoterol as the reliever inhaler, use pheno to diagnose, titrate, and monitor inhaled corticosteroid usage, especially in children, and preschool wheeze may be a pre-asthmatic state, and therefore intervene early and precisely. Thank you.
So that was great, Avya. I think only you could do it in one night, making a presentation about Gina and things that have changed last night. Thanks for summing it up so well. I think you've highlighted most of the important changes that have taken place. A lot of contemporary issues have been raised, and I think they would all need to be discussed further. So, the way asthma landscape is changing is actually interesting, and you've highlighted this so well, from just treating this with SOS SABAs to now talking about early biological therapy. The whole thing has gone a sea change. So we'll try to take a lot of important questions. Questions have already started pouring in. We've got a few questions ready. So can I please have the introduction slides for the panelists? All right. So to take forward the discussion, I have a lot of, I have a stellar panel with me. And the senior most is Dr. Sandhya Kulkarni. Pleasure to have you on board, ma'am. Ma'am is a senior consultant pulmonologist with 37 years experience. And despite being unwell, ma'am has joined us today. Thank you so much, ma'am, for being here. Then we have Dr. Gaurav Dubey. Can I please have his slide? Yeah. So Dr. Gaurav Dubey is a graduate from Nagpur and from Nanded, and he's an assistant professor and he's an associate professor of pulmonary medicine now, and he's a recognized PG teacher from MUHS Nashik. Thanks, Gaurav, for being with us here today. Can I have Dr. Atul's slide, please? Yes. So Atul, I know for many years now, pleasure interacting with Atul. Atul has an allergy and immunotherapy fellowship from Patel Chest and has also been trained in pediatric pulmonology. His area of interest is allergy, asthma, immunotherapy, and he's been a speaker and then participant at various national and international platforms. Thank you, Atul, for being with us here today. And Shreyami is a pulmonologist based out of CK Birla Hospitals, Kolkata. She comes from the most volatile state of India right now. Hope you are doing well and keeping safe, Shreyami. And good to have you here. Shreyami has been Dr. J.C. Kothari Young Scientist. She's won the J.C. Kothari Young Scientist Award at NAP1 in 2024 and has been a faculty at multiple national conferences. Pleasure having you all here. So, all right. Thank you, team. So we'll be taking
And
questions one by
before
one.
Arjun moves,
Yeah.
before Arjun moves ahead, let me have the pleasure of introducing the captain of today's ship, a very dear friend and a pulmonologist who needs no introduction, someone who's been doing excellent work in asthma and has achieved laurels which we all hope to one day. So Arjun currently works as the head of department and senior pulmonologist at the Amrita School of Medicine in Faridabad. Is an APSR fellow, trained at interventional pulmonology from Thailand, is a global rising star awarded in 2019 at the Lung Health Council in Nice, France. More than 100 publications and 500 plus invited talks and lectures, and has a special area of interest in pulmonary rehabilitation, palliation, severe asthma, and airway clinics. And someone I've always looked up to and learned a lot from speaking. So there's no one better than to talk on severe asthma than Arjun today. Handing
Thanks,
it
Avya.
back to you.
Thanks, man. So we've already talked about GINA guidelines and a lot of changes have taken place. Avya, your top three changes, your take on the three most important changes that every pulmonologist should know that have changed and have, been introduced in GINA 2026.
The three important changes, the first and the most important is that even in 6 to 11 years, ICS formoterol is the anti-inflammatory reliever therapy of choice. That is something which we all need to remember. The second most important and neglected is anaphylaxis and adrenaline. So epinephrine is something which has been advised as anaphylaxis and a rescue medication in managing asthma and anaphylactic reactions. We often neglect it, so that's something we need to remember. And using pheno as a biomarker We all know that pheno is present, but to titrate and understand the dose and how ICS needs to be adjusted, typically in children. So using pheno upfront, even in patients who can't perform a spirometry, is something which I would encourage all pediatricians and pulmonologists alike who manage pediatric asthma.
Sure, I think so. The emphasis now, as you very rightly said, is that we talk more about pediatric asthma because that's the crux of the matter. Asthma is a disease which classically affects the younger children, teenagers. And as pulmonologists, we've been practicing adult asthma. What we need to now focus on and change gears is we need to start seeing more younger patients. Unfortunately, our pediatric colleagues are not very well versed with the latest updates in asthma. And I say this with a pinch of salt, and I'm very scared saying this because my wife is a pediatrician and she's in the next room. But when I see pediatric prescriptions of asthma, it's still all SABA based. There is hardly any ICS. And if you leave alone using suggest drugs like formoterol or longer acting agents, the pediatricians throw a fit. So that's a huge problem. And you very rightly said that GINA guidelines now focus a lot on pediatric asthma. And the message to be put across here is that we as adult pulmonologists need to start looking at teenagers and give them the same benefit that we do to our adult patients. That is, start these patients on ICS LABA early. Do not shy away from using pheno upfront in these children. Do not wait for the airways to get fixed and think about biological therapy. The pulmonologist 2026 is thinking like the rheumatologist of 2005 when DMARDs and biologics were introduced for rheumatoid arthritis. In early rheumatoid arthritis, what was the fun of treating rheumatoid arthritis when everything was already deformed and, deranged and everything was scarred? The same principles now hold true with asthma, and that's where we are heading. That's pointed out really well, Avya. Uh, Sandhya ma'am, looking at the data from India, the InSearch data, the global data from asthma, India scarily is still the mortality capital of asthma in the world. We have the highest number of hospitalizations, we have the highest number of deaths, we have a very large pool of patients with severe asthma. Why are the Indian stats so scary, and what can we do to improve the situation?
Thank you. First of all, I would like to thank ICS for giving me this opportunity. And as you rightly said, Arjun, there is almost 13% global asthma cases in India and 46% global asthma deaths, despite holding small percentage of world population. There are 35 million people are affected. The most important part in India is almost 80% of them are underdiagnosed. And the crisis is because of underdiagnosis, high air pollution, stigma, reliance on oral medications instead of inhalers. Even in our practice, every one of us has already noticed that once you utter the word of inhaler, patient doesn't want to start on the inhaler. They will always ask you, is there any substitute tablet? Up to the extent that they are willing to take even oral corticosteroids, but they don't want to start with the inhalers. And again, thanks to our alternative therapy practitioners who always tell them about the side effects of the inhaled corticosteroids, which I feel is very important, and the health education, especially in this case, is very important. Another thing is, I see to it that every patient of allergic rhinitis, we should go ahead with the lung function testing. Again, pulmonary function test is totally underused modality in our country, because the moment you diagnose as allergic rhinitis, one has to go for a pulmonary function testing, because once you start getting allergic rhinitis, asthma will get unmasked. And if you can start at this at the initial part of the diagnosis only, if you diagnose asthma, you can start with a both, you can treat simultaneously. There will be a better control, so that the airway remodeling, the inflammation part, everything can be better. That is what is most important. Again, there is a paradox, like countries with higher prevalence like US, Europe, they have lower mortality, whereas India, there is a moderate prevalence but very high mortality. Almost 4.8 million Dalis are there lost annually, and 3 times higher mortality rate. So there is more disability, there is more hospitalization, and there is a worse quality of life. And that's why it is very bad, because mainly there is a underuse of ICS, and then the environmental role, underdiagnosis, and all that. So it is frustrating for a pulmonologist to explain the patients that why inhalers are very important. Even inhale corticosteroids in allergic rhinitis is very important.
That's put really well, ma'am. There is data from India which tells us that patients with psychiatric disorders and schizophrenia have higher compliance to therapy than patients with asthma. So really scary. I think we really need to break the stigmas ahead. All right. So Gaurav, coming to you, Avya has already talked about, and Gina 2026 talks a lot about pediatric asthma. And every time we see a child in the clinic, the patients, these kids come to us with Walry and wheezing associated with lower respiratory tract infection. And the standard question in the parent's mind is, will my child have asthma when they grow up? So, how does one tactfully and correctly answer this question? Are there any methods? Are there any flowcharts? Are there any algorithms which we see when we are treating, younger patients with asthma? And how do you answer this question whether your child will develop asthma or not?
Thank you for the question. First of all, thanks to Dr. Amita ma'am and team ACS. This question is really very difficult in clinical setting or practical settings because the parents are very anxious about the child, even more than themselves. So the counseling starts with the history of the parents, if they have asthma or not, maternal history, if the mother was suffering from asthma in the pregnancy, whether she has started or taken ICS in the pregnancy. So if pregnancy was, she has taken adequate control of asthma during the pregnancy. If the child is having allergic rhinitis or history of eczema, and patient's viral infections has been ruled out, then I will try to start with some inhalation therapy after adequate counseling and try to answer these questions in the second visit. Because in the first visit, the patient's relatives are so anxious that anything we are telling them, they are not willing to hear. They just want assurance that patient's asthma should go on by the age of 13 or 14. Actually, in previous textbooks, when I was PG, most of the guidelines say that in the age of 6 years or age of 13 years, the asthma will go in remission. But now recent GINA 2026 says that most of the child will surpass asthma by age of 9 years. But this will recur most of the time in adolescents as well as in adults. And that is what I am seeing in my practice. The most of the patients who were having remission at the age of 13, but now they are coming again and again because of triggers. So I will explain the trigger factors in second visit as well as importance of ICS LAVA combination treatment. And I will tell the patient's relative that if they are taking regular treatment, it will definitely have better remission and better growth of the child. Because at this age, not only remission as well as height and growth of the child is important. So counseling is a bit difficult, but overall patients get benefited by ICS LAVA combination. And once the symptoms improve, the patient's relatives are very confident in myself. So this is the way I get.
That's been put really well. I think we need not scare them in the first visit and tell them that they have asthma. Probably treat them, gain confidence, and take it forward. And there's this Tucson data from US, wherein this Tucson is a state in it's the capital of Arizona, and they had this linear data of years where they followed a pediatric population who had the wheeze associated with lower respiratory tract infection. And what they found out was that if there is history of asthma in first degree relatives, if the child has skin lesions or eczema associated with atopy, and if it's a male child, then the chances of them developing asthma as they grow older would be higher vis-a-vis if it's a female child, because of the hormonal changes that take place which are protective against asthma, if there are no first degree relatives who have asthma, and if there are no skin changes with asthma. So just a pointer there that if you see these kind of patients in childhood with skin lesions, with first degree relatives of asthma, and male children with asthma, you need to be careful with them. But that's a very well taken point.
That should be ruled out.
Sure. Atul, coming to you, asthma has always been a clinical diagnosis. We always harp about saying that PFT is not there and it's underutilized in our country. On the other hand, there are things, which are overutilized in our country, wherein, a lot of unnecessary tests are done. So, what is the rational workup of a patient with asthma? As a pulmonologist, what is the minimum set of investigation and the most rational set of investigations that should be done to rule in or rule out asthma?
Firstly, thanks to ICS for this opportunity. As you rightly told, sir, asthma is mostly a history. Many of the things are diagnosed right away from the history. But from the basic set of investigations which we are necessary, the first thing definitely what we go for is a spirometry. Spirometry, and we look for the post bronchodilator reversibility. Now, if the patient is too old to and unable to perform a spirometry, or if it's a child, as you told, now we are going towards early pheno, even in children who are unable to do a spirometry. You can even do an impulse oscillometry and see whether you can diagnose asthma. And secondly, the other thing is you can always do a chest X-ray to rule out other causes, just to make sure that you are not just dealing with asthma or something else is there, something there, some sort of an airway abnormality or a parenchymal abnormality is there in the lung. So you have to rule out that as well. And basically, what we have seen is in many of the patients who come with asthma, they just come with a report of IgE. I have seen many patients coming with a serum IgE report. Now, how important is that in early diagnosis of asthma? I'm not that sure. But later, if the patient is not responding to treatment, obviously you will need to phenotype, and whether you are dealing with a Th2 low asthma or if it's something that requires biologics or if you have to rule out ABPA, then obviously you have to do a serum IgE and an absolute eosinophil count, etc. Now, even an eosinophil count can be useful, especially in my part of the world where you have a lot of parasitic infections. So that also needs to be treated underlying. So basic investigations, if you see, firstly, you can go for spirometry. And obviously, people also say peak inspiratory. The guidelines also say you can check a diurnal variation of your peak expiratory flow rate. Then you can do an X-ray to rule out other causes. And obviously, if it's not responding to your first line of treatment, you can use the other diagnosis, other diagnostic tests like your eosinophil count, IgE, and other markers to make sure that you are dealing with an asthma and to rule out other causes which you would have missed, because sometimes from the history you might think it's just an asthma, but you might be missing out on something.
Sure. So that's a very, very important point. Asthma has a lot of clinical mimics. So though the definition remains clinical, you very often see things like COPD, bronchiectasis, tuberculosis, vasculitis being treated as asthma. So the workup should A, first diagnose asthma confidently, B, rule out the other common differential diagnosis, C, if it's a patient with difficult asthma, difficult to control asthma, or true severe asthma, then our investigations should be aimed at phenotyping the patient, whether the patient is Th1 or Th2. But all investigations in India is a very, very cost sensitive market. And we all need to understand that things like impulse oscillometry, which have not been validated for the diagnosis of asthma, are not necessary. If you have it, well and good. But it's, things like pheno, if you are running a severe asthma clinic or if you're dealing with pediatric asthma, it's okay. But even if you don't have access to high-fangled investigations like iOS, Pheno, or sputum eosinophils, please remember that the diagnosis of asthma is a clinical diagnosis. And you're absolutely justified in giving the patient a benefit of ICS LABA if you think the patient is asthma. In the meanwhile, please keep ruling out other differential diagnoses. I think you've put it really well, Atul. Coming to Shreyami. Shreyami, I think this happens very frequently in my part of the country. Any patient with so-called asthma comes to me with a report of a skin prick test or an allergy blood-based test. This kind of a test in Delhi NCR would cost somewhere between 15 to 25,000 rupees. The patient hands me over a report which is 10 pages long. They're allergic to everything that they have eaten since childhood, including dal, chawal, all vegetables, and all kind of fancy scientific name of trees that exist in the country are there in that report. What do you make of these reports? Is it necessary to get all these skin prick tests and allergy panel done in all patients of asthma? What is the rational way of doing these allergy tests in patients with asthma?
Okay. So at the onset, thank you, ICS and Amita ma'am, for this opportunity. And yes, in our part of the country also, all the people who are referred to us come with a large panel of allergy tests and everything. But this allergy test, the panel of the large allergy test, they are the multiplex panel with dozens of allergens done without a clinical question. Like they have not been asked about the history. They are just been advised ki you do the allergy panel test and come back. And therefore, they generate a long list of positives. But this positive only means they are sensitized to the allergen. That does not mean they will mount an allergic reaction to the same. Therefore, this panel should always be done keeping a background of history. We should take a proper history first and then do the test and then take the report with a pinch of salt. They also divert the attention from the core asthma management, for example, the ICS adherence, the inhaler technique, and environmental control towards changing every zero point 0.4 liters of vessel that gets changed. So only the thing gets positive on the allergy panel, and therefore you have to avoid it. No, it is not like that. It it should be more patient to patient centric based, history based, and then only tell the patient to avoid it.
Fantastic. It could have been not put more succinctly.
Yes.
That's very well taken. I am so sad and I'm so irritated with these panel reports which come all the time. And one very important point that you've said is it takes away from the actual seriousness of the issue. Rather than spending time with them on how important the inhaler is, we spend time on, fighting with
What to
doodh
avoid.
dahi chawal and the same conversation keeps on going on again and again. Seb kha le, papita kha le, and all this,
And
that is what we really need to change now. Very well said, Shreyami. Very well said. So, moving to Avya. Avya, Gina has done away with the blue inhaler, and the world over, blue inhalers have been done away with. Uh, I was just looking at India's, big data yesterday. As of now, it is still said that 80% of patients who have asthma, this is market surveillance data from last year, 83% patients who had a clinical diagnosis of asthma went to the chemist and asked for the blue inhaler. Now, data very nicely tells you talked about the Sigma trials, which said that patients need to be on ICS LABA. GINA 26 talks about the Butara trial. Butara trial is about ICS SABA. So earlier guidelines said that every time that you're giving a patient ICS, a LABA, please add ICS with it. Now with the Butara trial in GINA 2026, every time that you're giving a patient a SABA, an ICS is to be added with it. So Avya, how does India do away with the blue inhaler? Where's the glitch and how do we get away with it? Is
It's a
Avya
very
there?
tough one.
Yeah.
It's a very tough one. It's going to be a slow progress. It's not going to happen overnight. It's because of the first and foremost important aspect is that we need to instill the confidence of the inhaled corticosteroid not in the pulmonologist, but in the allied medical specialties. When we speak of medicine practitioners, when we speak of general practitioners, we need to tell them not to scare the patient of the inhaled corticosteroid, because the very time the patient comes to us, they ask us that does this have steroids, and they have been brainwashed over decades and decades by telling that this inhaler is addictive, this has steroids, and this causes harm. No one has ever spoken about the benefits of the inhaled corticosteroid and of the harm of not taking the SABA, of taking the SABA prolonged. Now, Sandhya ma'am rightly said that 13% of the world's asthmatics and 40% of the world's mortality has got a lot to do with the SABA use and abuse. I don't say use of SABA, I say abuse of SABA in our country. And very often I've seen patients who've been switched to ICS formoterol by me still keep that SABA in the pocket because of placebo of feeling the sense of security which they have. So let's start by educating our fellow colleagues from allied specialties about the safety of ICS. We keep giving talks to pulmonologists and telling them they're going to read GINA anyway. We need to start telling the general practitioners that listen, ICS formoterol though, hamare paas patient mat bhejo, that's all right, but please give them ICS formoterol as the first inhaler and educate them. Number one. Number two, the pharma driven initiative also has to be very, very important, that OTC sale of salbutamol should be restricted. I mean, I know I'm talking of a very far-fetched concept. It's not going to be happen, but please ensure a prescription is given for the inhaler. The minute you have a prescription of the inhaler, you can trace back as to where the practice is going wrong. And that is how we can start educating even the grassroots level by keeping a track of the abuse of SABA which is happening in our society. And third is most important, creating patient awareness. Having more ads, more flyers, advertisements. Maybe all the pharma companies can come together and just put a full page cover ad on any newspaper telling that ICS formoterol is the safest inhaler in asthma. Go away and do away with the blue inhaler. I mean, if an inhaler sells, all of them will make money, but getting the push is very tough. The other hindrance in India is the sheer amount of money which the salbutamol sales make. So no company will vehemently tell you that, no, I'm not going to sell this inhaler anymore. It's going to be a big financial setback for them. No one's going to take that upfront. So rather than telling them to stop the sales of Saba alone, maybe these few measures can be adopted across practice.
Fantastic. Very
Arjun, can I make
passionate.
one point?
No, ma'am, please.
See, the blue inhaler is the cheapest medicine as far as asthma is concerned. If you add ICS, it adds to the cost. So many times, maybe it is the cost effectiveness which makes them continue
Sure.
the blue inhaler, and the immediate relief what they get may be temporary.
Sure, ma'am. And as Avya very rightly said, it's about training the allied health sciences. It's about training the internal medicine crowd about ICS LABA. For example, a very small thing that we did in our hospital was, as a part of a project, we said that all inhalers, all SABAs should be endorsed by a pulmonologist. And if any other department is writing a SABA, that prescription needs to be co-signed by a pulmonologist. So this was, initially the internal medicine department and others were up in arms that how can, these guys just tell us not to write SABAs. But it's been now 3 years that this has been in practice, and our hospital sells almost no SABA. So, sometimes you need to do drastic things to make a point. And Avya said it very passionately, and that's correct. Sandhya ma'am, coming to you. Every time you see a prescription of asthma in India, it's full of polypharmacy. Everyone is on multivitamins, everyone is on, oral theophylline. And one of the biggest additions in any asthma prescription is Montelukast, and Montelukast with a combination of other anti-allergics. There is a US black box warning with Montelukast that it increases suicide ideation. If you look at the packets of Singulair from USA, it's like the cigarette packets from India where, you see Ashok's face with that cancer. It's the same thing in US. You see a packet of Singulair, that's the Monter over there. You see a kid who's, committing suicide. But in India, this is so rampant, at GP level, at allied health, Ayurveda, homeopath level, everyone has that combination of Montelukast with levocetirizine. What's the rational prescription of Montelukast? When should a pulmonologist write Montelukast? And what's your take on it?
It's not actually the first line treatment as it is practiced in our country. Again, it is, as I said, most of the GPs, they start even during the childhood, and probably it gets continued throughout the adult life because patients don't come to you, taking tablet is easier. And maybe that could be the reason. But it's always an alternative or add-on therapy. It's inferior to ICS for symptom control and exacerbation, obviously, because it doesn't consider the inflammation part to that extent. It has a stepwise role. It is used in mild step 2 in mild asthma, but only when if ICS is refusal or there is an intolerance to using ICS. And one has to consider adding ICS only. And in spite of that, if there is a inadequate control, then may consider adding this Montelukast. It actually, when the allergic phenotype is present, that works better, and in exercise induced asthma, in aspirin induced asthma, but it is still less effective as compared to LABA. So one must start with ICS, add LABA. In spite of ICS LABA, if there is no improvement or there is associated allergic phenotype, then consider adding Montelukast. There are side effects, as you mentioned, about the neuropsychiatric side effects, sleep disturbances, anxiety, mood disturbances. But the combination is useful in asthma and allergic rhinitis. So there are only limited indications where one can use it generally. If there is a refusal, asthma and allergic rhinitis associated, or if there is this better control of nasal symptoms and nighttime symptoms. Obviously, Montelukast is prescribed at nighttime, and there is some sedative effect with this combination, so sometimes which helps in anxiety reduction in these patients. And wherever strong atopic profile is there, obviously one has to use it in especially seasonal variation and eosinophilia.
So as they used to say that, fever is not a sign of ceftriaxone deficiency. So similarly, asthma is not a sign of Montelukast deficiency. You need not give it to all your patients. It is expensive. If you buy a tablet of Montelukast with levocetrazine, it is to the tune of 15 to 20 rupees. So when you actually go and buy it, you realize that, oh, this is expensive. And, you need to save a lot of money for the patient when you prescribe them unnecessarily. So please give them only for TH2 comorbidities. There is very nice data which tells us that when you add anti-allergics unnecessarily to a patient with asthma, upstream the biomarkers, the cytokines actually increase and they add fuel to fire to the asthma inflammation. So unnecessarily giving anti-allergics to patients with asthma can actually worsen the asthma. So that's a point very well put by ma'am. Coming to Gaurav. Gaurav, GINA, actually, the problem with GINA is that it is a global guideline and they need to do stuff which is available everywhere. So the problem with for example, when you talk about anticholinergic therapy, tiotropium glycopyrronium, the problem is that these drugs are not very easily available in the African subcontinent. On the other hand, if you look at the American guidelines, the European guidelines for asthma, you see drugs like tiotropium glycopyrronium in the NICE guidelines being added in step 2 asthma. Whereas if you look at GINA, it is still reserved for step 5 asthma. So how does one, the answer, the reason that GINA gives is that we are making a global guideline. And because we cannot prescribe anticholinergics at step 3 asthma, because a lot of Asian countries, sub-Saharan Africa would feel left out. So that is why we are placing GINA, anticholinergics in step 5 asthma, so that only the patients who really need it would get it. So what's your take on anticholinergic therapy in asthma? What's the right way of placing anticholinergic agents in that GINA step ladder?
Initially, I want to tell you the drug that should not be given singly in asthma is anticholinergics. It should be started after full dose of ICS, that is medium to high dose ICS plus LABA combination. It has been started. Patient is taking adequate doses as well as good adherence is there. Proper technique is there. Even if patient is not having symptom relief or remissions, then we can add. The advantage is patient will have better lung function, reduce exacerbations. But symptom reliefs are not so good as per ICS LABA combination. So it can be added in step 5 step of GINA guidelines, as well as the major benefit is in patients where neutrophilic asthma is present. If type 2 inflammation is there, the chances of relieving of symptoms are very less. There are 3 approved GINA anticholinergic LAMAs are there. First one is tiotropium, which can be given in children more than 6 years of age, glycopyrronium more than 12 years of age, and umeclinium at about 18 years of age. You can use in combination that 3-in-1 inhaler device or LABA plus ICS and separate LAMA combination, LAMA inhaler device. If patient is having exacerbation on all these 3 drugs, patient can again use LAMA plus ICS, that is formoterol ICS combination, or if not possible, then can be LAMA ICS plus SABA combination can be used for exacerbations. So LAMA can be useful. Recent trials have shown its effectivity not only in exacerbation but also in lung functions. But obviously, there are side effects like dry mouth and urine retention, especially in old age patients. There are some reports of arrhythmias with tiotropium also. So we have to use cautiously, especially in elderly population. The use of tiotropium as glycopyrronium has been increasing in adults and adolescents because of newer guidelines. I am also using it in my step 5 patients of asthma. If patient is not responding to ICS plus LABA combination, I will prefer this combination more than oral. Obviously, the patients take away because of financial issues and cost of the therapy is definitely difficult to convince the patient. And dryness of mouth is a common side effect that does hamper the use of this inhaler combination.
That's a point very well taken. And this year, Gina specifically talks about omeclinidium and glycopyrronium, thankfully, has been added to the guidelines because we were using it anyways, And you've said this very well that patients who are not doing well on a good dose of ICS LABA, rather than shifting on to other drugs which are more harmful, like oral steroids, or giving them drugs like, say, oral theophylline, when there is not much data involved or not much data around, it is more rational to treat these patients with anticholinergic therapy, because when you give LABA with LAMA, the bronchodilation that takes place is actually additive. It's exponential. So the LAMA would act more on your central airways. The LABAs would act more on your peripheral airways. So when you give it in combination to patients who have a persistent airflow limitation where the lung functions in low, probably you need to look at this treatable trait, where the treatable trait is persistent airflow obstruction and a low lung function. And if this is the guy who has difficult asthma, then probably, the right drug to add would be the anticholinergic therapy. So something to look forward to in GINA 2026, a new chapter added on anticholinergics in asthma. And they now talk about data with omeclinidium and glycopyrronium in more than 12 years of age, omeclinidium in more than 8 years of age, and tiotropium in more than 6 years of age. So our pediatric colleagues would throw a fit using drugs like tiotropium in 6 years and plus. But I think this is a point very well taken. We see these children suffering, 7-year, 8-year-old kids with severe asthma, with lung functions 21%, 30% FEV1s, and no one, tries to give them LAMAs. But this year, GINA makes a good stand, and our pediatric patients, teenage patients with severe asthma, persistent airflow obstruction, a good point now is that anticholinergic therapy can be used in these patients. All right. So coming to Atul. Atul, the step up, step down flowchart of GINA has always been around inhaled steroids. Does this make sense? If I have a patient who has worsening shortness of breath because they have sleep apnea and obesity and anxiety, but if I work them up with the GINA step up ladder, the treatment would be, because this patient is asthmatic, not doing well, the treatment would be increase the dose of the inhaled steroid. GINA very, very, politically correctly says that we are a global guideline and, we have to send the standards for the whole world. And that is why we say that, the patient is not doing well, you increase the dose of the ICS. Practice, we often understand that this is not correct. What is correct is looking at a particular reason why that patient is not doing well and then doing the needful for that patient. So how do you place this stepping up of steroids, stepping down of steroids because the patient is not doing well? You think GINA needs to take a re-look at this? Are we still living in the 1990s where any worsening increased the ICS, any good lung function decreased the ICS? How do you look at this? I think this is very, very primitive and this needs to be changed. Your thoughts on that?
Yes, sir. The thing is, the problem here is we keep on increasing the dose of steroids, and only in the step 5 we are looking for alternative diagnosis. That is where the issue is. So what I feel is, if you are initially starting on an inhaler like a LABA ICS combination, and if your patient is not responding to that, and you feel your diagnosis of asthma, I think you should go back to your primary diagnosis and to rule out other things. And the first thing I think we should all check is the inhaler technique, whether the technique of using the inhaler is correct, whether the patient compliance to the inhaler is correct, whether he has other comorbidities or other habits like smoking, or whether he is exposed to toxic pollutants or air pollution. And the most common comorbidity which we all face in asthmatics is gastroesophageal reflux disease, and second is obesity. So the thing here is, in asthmatics who are obese, now how much of their breathlessness is attributed to the obesity per se? As we all know, if we are obese, we have a decreased exercise capacity. We'll always have a breathlessness on exertion. So just that increasing your dose of steroids won't help much there. So if you feel that if you're if you are putting the patient on an initial treatment, whether it's step 2 or step 3, whatever, and if you are not seeing a improvement in your patient, I think we should at that step itself go back to our diagnosis and rule out other causes and take care of all the contributing factors as well. And many a times I have seen that most of the uncontrolled asthma patients which we have, or which I have seen in practice, is that they have a wrong inhaler technique. So that is one thing which always comes up. So sometimes just by correcting the inhaler techniques, you can save the patient from just increasing the dose of steroids, and always look for alternative diagnosis. And decreasing the steroid dose, obviously, if you have started a patient on treatment and if you have seen that he's improving, whether you are taking the follow-up at 3 months or 6 months, you can obviously down titrate the steroid dose so that you can keep it at the lowest possible dose, so that whenever he has an exacerbation and you are forced to increase the dose of your inhaled steroids, you can increase the dose there. So I think that the point that where we are going at alternative diagnosis and whether we are phenotyping at step 5, I think we should do it at an earlier stage, I feel.
Sure,
Rather
that's
than
the
going
point. Sure.
at step 2 or step 3, if you do that, you need in unnecessarily prolong the delay the diagnosis. You are and the thing is, if you are missing, if it's an old age patient and you are putting him on inhaled corticosteroids for no reason, and that to a high dose of inhaled corticosteroid, there are other comorbidities that can come up like osteoporosis and other things. So I think that evaluation should be done at an earlier date. Initial treatment is okay, and initially if he's not responding, I think you should always rule out the other causes rather than just increasing the steroid dose.
Sure, that's a point very well taken. So the other way of looking at this is look at treatable traits. When you talk about rare things like, advanced lung cancer, and you talk about personalized therapy for that, and you talk about all those expensive high-fangled molecules, why not do it in something as basic as asthma? And this is what Avya was talking about. This is a concept that has been given by Professor Mario Cazzola, treatable traits in asthma. I think it's a very, very relevant, a very contemporary, a very hot topic, and one cannot talk, more about it. Shreyami, what is this concept of treatable traits in obstructive lung disease with reference to asthma? How does a pulmonologist look for important treatable traits in their clinical practice?
So these treatable traits, they are specific, sometimes measurable and clinically important features, and that we can identify and modify in each of our patient at each and every visit to improve the outcome and achieve the remission of asthma that we were talking about. We should always remember this asthma is a heterogeneous disease. For example, two patients are at the same gene step, but they can have completely different biology. One might have the eosinophilic steroid responsive patient, and another might be a neutrophilic, obese, largely steroid insensitive patient. So, if we just go on increasing the stepwise approach, one might be a very good response, another patient will not give us response. For this, here comes the treatable trait option. So what are these treatable traits? So these are the modifiable features, and they can be grouped into three domains: one pulmonary, extrapulmonary, and third is the behavioral or the lifestyle. The most important are the pulmonary traits, whether the patient is a eosinophilic inflammation, whether he or she has a fixed airflow obstruction, a chronic inflammation, frequent exacerbating type, any other chronic lung disease such as bronchiectasis or EBP associated. Sometimes there may be extrapulmonary features which are associated, for example, obesity, OSA, chronic rhinosinusitis with the nasal polyposis, GERD, and then another behavioral lifestyle. For example, patient has anxiety-related asthma, poor adherence technique, the most common cause, the incorrect technique, the smoking, their constant exposure to the passive smoking also, doing all the indoor smoke, the biomass exposure. So all these are treatable state, and at every visit before stepping up your treatment or before stepping up the low dose to medium dose ICS, always ask for these traits and try to modify this first. And this will help the patient more, and then of course decrease the dose of the ICS and defer the side effects as well.
Very well said. It's about personalizing therapy. Now, a patient with asthma might be breathless because they are obese, because they are anxious, because they have sleep apnea. So rather than increasing the dose of the steroid, what the current GINA guidelines tell us is look at the treatable traits, look at the comorbidities, look at why this patient's asthma is not controlled. Treat that trait rather than blindly increasing the dose of the inhaled steroid. Once you have done all that, and the patient continues to be bad, then increase the dose of the inhaled steroid. That's the crux of the matter. So personalized therapy is the way out of this misery, and that's what all of us need to practice in our daily OPDs. A very important and a very contemporary concept is the carbon footprint, the environmental footprint of asthma therapy. We all know that inhalers do have an impact on the environment. And how do you dispose these inhalers? The inhalers are bioactive. There is a bioactive hazard in inhalers. Do you ever tell your inhalers how to dispose them off? One throws them in the red bucket, blue bucket, the black bucket, and or they go into the domestic dustbin. How does one deal with this? The amount of plastic burden that is inhaled, that is generated by inhalers is huge. The amount of carbon footprint of a single canister of inhaler is like driving an automobile, a car for 200 kilometers. So it's a huge carbon footprint, a huge environmental footprint that these inhalers have. What do you do about that, and how do you dispose of these inhalers? I know this is a topic that is close to your heart. So what do you do about it?
So inhaler disposal, I mean, we've spoken about this, Arjun, privately as well, is something we never speak about. We had a recent data which we did, and we'll be publishing it soon, of about 160 patients, and 80% threw away the inhalers, 20% gave it in household waste, 5% flushed the inhalers, and about 3% burned the inhalers. So you can imagine the amount of carbon footprint which the inhaler disposal actually has. No one talks about how do you do and what do you do with the inhaler. UK, the Take Care program, by just taking back 20,000 inhalers from patients, saved about 119 tons of carbon dioxide emission. That's a huge number. The pharmacy take back approach should be incorporated. Patients should be educated as to give the inhaler back to the pharmacy or speak with the biomedical, with the municipal corporation and tell them that this is a potential biomedical waste. Please tell us how should we dispose it. Throwing away the inhalers is not the solution. What we've started doing is we've started keeping these boxes outside our clinics where we encourage patients to bring back their old inhalers on follow-up and discard it, and we ensure we discard it and dispose it for them. We've started telling patients, sending them messages when we started doing this so that adequate exposure and discarding of inhalers is done properly. We should learn from our southernmost state, Kerala, where they had the IMAGE and the NPROUD program by which they ensured that the inhaler disposal was done adequately for all patients. I mean, I learned this at home. I never thought about the inhalers and how it used to be disposed. I've been treating my mother for asthma for 10 years, and we never spoke about disposing the inhalers. And only when I read about the Sabina data and I read about inhaler disposable and Take Care and everything and IMAGE and NPROUD, did I realize that I was making a mistake myself. And that's the time I adopted a change. So you see, it's never too late to tell our patients that you need to take the inhaler to the correct disposal. This is a biomedical waste. It needs to be discarded in a proper way to prevent further damage to the environment with the greenhouse gas effect, with the carbon dioxide effect. And that's how we're going to work. We need to wait still for a couple of years or 5 years before we have all the products, all the chemicals in the inhalers which are environment friendly, or they come down to the greenhouse footprint of DPIs. But that's a long way to go. Patients are still going to be on MDIs, and we need to educate them how to dispose it. So a way is to take back the inhalers, tell them to bring it back to your OPD, or ensuring that they communicate with your municipal corporation for safely discarding and disposing them.
Sure, that's a long shot. Let's see what happens there. Sandhya ma'am, when you come talk about pharmacotherapy, you name the agent and that would be available in India. When you talk about inhaled steroids in asthma, budesonide, fluticasone, propionate, fumarate, cyclosonide, mometasone, everything is available in our country. So is there a choice between the inhaled steroids? Is there a favorite? Is there something which is preferred? How do you choose between inhaled steroids in a patient with asthma? Now, Gina, because most of the trials have been done with, formoterol, budesonide, Sigma trials were with this particular combination. So to talk about budesonide. Budesonide is something that has been talked about for a long time, but we have all the other combinations available in our country. So how does one rationally choose the inhaled steroid in asthma?
Actually, all are not identical, but in routine asthma care, they most work similarly if used at equivalent anti-inflammatory doses. And the equivalent anti-inflammatory doses are mentioned in pharmacotherapy books and even in guidelines and everywhere. So the only difference is in the pharmacological potency, lung deposition, systemic exposure, and from practical point of view, the device, dosing, and the cost. So when we talk of potency, fluticasone, either it is furoate, propionate, both, it is the potency is always better, the most potent drug. Next to that is the budesonide, and beclomethasone is similar potency. Mometasone and cyclosonide are there, but then mometasone and the cyclosonide cannot be used in the emergency setup. Whereas with the current MART therapy, budesonide is the most one which is preferred because comes in the combination with the formoterol and can be used as a MART therapy. So doses are not interchangeable, and 1:1 dose cannot be used in any patient anyway. Whereas when we consider about the lung deposition versus systemic deposition, again, fluticasone has a highest first pass metabolism, so it has a lower systemic side effects. Particle size and formulations, when it comes in the beclomethasone, it comes in the it comes in the ultra fine particles. Cipla has come out with the Nivioli inhaler, which is ultra fine and can be used with the small airway for that deposition is better in these small airways. With fluticasone, the dosing convenience can be given in a single once daily dose, whereas budesonide cannot be given in a single dose. So the working class or who has a tendency to default, their single dose inhaler is most preferable, because even if he takes a single dose at night time or in the morning time, once your work is done, because it will work for almost 24 hours. Another thing is device also matters as much as the drug. So technique errors can reduce lung deposition by more than 50%. So it is always important to check the technique at each and every time when you prescribe any inhaler. And the more important thing is using the device when it comes to molecular choice. When does the choice matters? Molecular choice, when again, as I mentioned, where is poor adherence, then if those who are frequent exacerbators, there again the choice matters. And one has to consider the side effects. As far as where the systemic bioavailability is poor, those can be used in patients where we have a huge burden of post-TB patients who need inhaled corticosteroids. So there we can consider. Cost effectiveness again is very important, and budesonide, beclomethasone are more affordable as compared to fluticasone, which is little expensive. Mometasone has a high receptor affinity. It has a low oral bioavailability. It has a high first pass metabolism. It has a strong local effect, and it has minimal side effects, but it has limitations. It cannot be used in the MART therapy, as I mentioned, like budesonide formoterol is the combination which has been recommended by GINA in the MART therapy. So, and it is expensive also. So that depends like which you should use depending on the patient's acceptability, sort of.
So the whole plethora is available in our country, and you really need to choose wisely. So we've got close to 100 questions now. I'm only selecting the questions that are being repeated again and again, and I'm because otherwise it'll get people are asking me to detect data on ipilimumab, things like this are coming up, which I'm obviously not going to take up. So I'm taking up the most clinically relevant questions and the questions that are getting repeated most often. Gaurav, coming to you, you cannot have a discussion about obstructive lung diseases in India and not talk about oral therapy. Gina, Gold are never going to, publish this. None of the pharma companies are going to support this. But Indian patients with asthma, deriphyllin, drugs like acebrophylline, doxophylline, they rule, the Indian pharma market. So what's your take on oral bronchodilators in the management of asthma in 2026? Where do we place them?
Really, GINA has not given them a preference. GINA has given the theophylline as a last drug in step 5. Oral sustained release low dose tablet or theophylline can be used in step 5 as GINA has said. But obviously, we are seeing all the patients, maximum number of patients who are taking asthma medications are having some or other oral medications, especially salbutamol or theophylline drug. Theophylline, nowadays we are also using acebrophylline in some patients who are unable to take proper inhalation therapy or not well controlled on inhalation therapy or having exacerbations, especially some infections, patient coming with some infections, LRTS. So we have to give them some oral inhalation, oral bronchodilator therapy. In these cases, we can give it. Otherwise, the oral role of bronchodilators is limited because of short duration and excessive side effects. Initially, in previous days, we have also used IV aminophylines also, but that can cause severe tachycardia, arrhythmias. So it's outdated now. The injection adrenaline has been given in previous days, but that is also outdated now. Only things we have now is oral theophylline drugs. Other drugs are not so indicated now. Only in step 5, if all the things have been done, proper adherence has been taken care of, patient is taking oral ICS LAVA combination in proper doses, and patient is not having any other trigger factors, then patient can be started on theophylline group. I rarely start with theophylline, but I have to add on if patient is not improving, and especially patient is having some community acquired pneumonia, then these drugs do some work. That is my personal experience.
Sure. I think, we always look down upon things that are very Indian, and because none of the pharma companies, none of the Western players are ever going to come out on data with oral theophylline, ciprofilin now. Uh, the onus is on Indian pulmonologists to actually come up with data on these drugs and tell us whether they're effective or not. We've always been told that theophylline and they have a lot of side effects. But tell me, hand on your heart, do you see a lot of side effects with oral theophylline in your practice? I don't. I've hardly seen any patient ever react violently to, theophylline. But we've always been hammered that, these are bad drugs and they should not be used. And this is a very Western point of looking at things. What do you give to a 15-year-old girl who comes with severe asthma to your clinic, where the family says that we are not going to use any inhaler for this patient? It is, I would much rather keep my child at home rather than giving them an inhaler. So I think this kind of data can only come from India, rather than looking down upon drugs like these, which have been used in India for decades altogether. Come up with data from India. There are a lot of young children, young crowd today who are listening to us today. Why not do research on this, and say that it's not as bad as it is made out to be? We are not supporting the use of theophylline here. That's not what my point is. Obviously, all patients with asthma should go home with ICS LABA. But everything that is brown and Indian is not always that bad. I think we really need to look at these things more
Things
often.
like research.
Anyways, yeah.
Shall I
But
make one comment, Arjun?
sure, ma'am.
See, I was in a municipal corporation for almost 14 years, and that was the cheapest drug like Astalin and Derifylin. These were the cheapest medicines which were available, and we used to give it to all our post-TB fibrosis patients where we couldn't use ICS to that extent. So sometimes it happens that you can give a very small dose of ICS to these patients and then continue with oral because it's easily available in government hospitals. Patients continue to take it because it's a very cheap medication. And even in private practice, many times what I do is still I come to a conclusion that I'm going to start this patient on inhaled corticosteroid because the acceptance is not that good if you prescribe a long term inhaled corticosteroids. So till I diagnose, till I confirm, I make them, I counsel them and confirm that there's no, she needs inhaled corticosteroids. Still then, even in my private practice, I give them regular theophylline or doxophylline or whatever, and the acceptance is very good.
Ma'am, we all do that, but we are not allowed to say that out loud in public. So, anyways, when we need more data on that.
I know.
So, Atul, coming to you, this is one of the most difficult patients that I see in my practice, and I absolutely hate seeing these patients. When I see a severe asthma with Th2 phenotype, I'm very happy because I have something to do with them. I can give them a biologic, I can play around. Th1 severe asthma where eosinophils are not high, IgE is not high, FeNO is not high. You are stuck up with these patients. You give them everything. You give them azithromycin, you give them doxycycline, you advise weight reduction. Earlier, bronchial thermoplasty used to be there. Nothing works for these patients here. You really don't know what to do with these patients. So, Atul, what is the actual way of looking at Th1 asthma in clinical practice? How do you manage Th1 high or Th2 low severe asthma in clinical practice?
Yes, sir. So when we are talking about Th2 low asthma, the first thing we'll be always looking at that it is the comorbid factors. Like smoking is there, smoking cessation, any environmental or occupational exposure. Take preventive measures. If there is a concomitant obstructive sleep apnea or OSA, you can treat that. And so basically looking at all the comorbid factors that are there. The other options which we have is adding a LAMA to a, if it's a LABA ICS patient, you can add a long-term muscarinic antagonist. So as you told, there is an increased bronchodilation with that. So I have seen some patients respond to that, not everyone, but I have seen some patients respond to that, predominantly those patients who have more of a dyspnea rather than exacerbations. And other options which we have is a macrolide prophylaxis like azithromycin, especially if it's a paucigranulocytic pattern. And as you rightly told, we don't have biologics like what we have in a Th2 high phenotype. But as I was going through the lecture which was given by Sir, in that he told there is an alarmin which is there at the top, tezepelumab, which can be used irrespective of what your Th2 status is, whether it's high or low. Now, that can be a useful biologic that can be used, but always the thing is to look for alternative diagnosis and treat the other things. And these are the treatment options which we have. And obviously, you can do an HRCT and see if we are missing out on something on the X-ray. And always try to maintain an BMI, normal BMI. And one more thing which we miss, especially in that patient who have kind of a bronchitic or a coughing type of asthma, which they say. Now, many of the times we miss out on reflexes, gastroesophageal reflux disease. We miss out on hiatus hernia in many of those patients. So always keep in mind that diagnosis as well, especially if it's an obese and all that, and you get the classic reflex symptoms when you're taking the history properly. So I think gastro reflex also is something which you have to treat, because that in turn, many of the patients, at least 60 to 70% of those patients have a reflex that is always causing that cough, and that in turn will cause a GERD associated breathlessness. And the thing with asthmatics is they will always attribute any breathlessness to asthma. So they'll obviously use an inhaler as a reliever, but that might not always relieve your symptoms. So I always feel that gastro component is very, very important. And especially if it's a predominant dyspnea that is there rather than the exacerbation or nocturnal symptoms, always look out for the cardiac component as well, whether we are missing out on something there as well.
Sure. So the crux of the matter is to look at the treatable traits. Now, when because a lot of patients with so-called Th1 asthma would again have a lot of treatable traits that need to be taken care of. Professor Cazzola, who has introduced this term of treatable traits, in his paper, he talks about a web of treatable traits, that in every patient with asthma, there would be multiple treatable traits that can be taken care of. In a patient with severe Th2 asthma, it is said that on an average, there would be around 4 treatable traits. Whereas in a patient with Th2 low severe asthma, 7 to 11 treatable traits would be there. So the crux of the matter is that when you are looking at Th2 low severe asthma, you need to just not look at their asthma. You need to see the patient in detail. There would be so many comorbidities over there. Obesity, of course, is one of them. Post-menopausal late onset severe asthma, which has now been added as a new phenotype of Th1 severe asthma in GINA 2026, is one of the most important clinical phenotypes of severe Th1 asthma that we see in our clinical practice. Elderly post-menopausal women starting with asthma at 60 years of age, most difficult patients to control. So, these are the treatable traits that you need to take care of. And just don't look at their lungs, look beyond the lungs in these patients. That's what the message is, right? Shreyami, talking to you because this question is coming up again and again. Shreyami comes from the land of Ma Mati Manush. I don't know whether we are allowed to say that anymore, but it's we always talk about in India at a very grassroots level. And a pulmonologist is a poor man's doctor. A cardiologist is a rich man's doctor. No one ever argues if you put a stent of 4 lakh rupees, but you talk about a biologic of 60,000 rupees and everyone loses their mind. Pulmonologist is trained to look at patients that ye to gareeb hain, ye to bichari, they won't be able to ever afford a biologic. So there's this poverty of thought of the Indian pulmonologist that our patients would not be able to afford a biologic. We have this paper which is under publication where we looked at the cost effectivity of biologics. We found out that patients who have severe asthma in India, they spend close to a severe asthmatic in India when you take into account their admissions, exacerbations, drugs that they use. Somewhere between 30 to 38,000 rupees they spend every month on the treatment of severe asthma. On the other hand, if they're shifted onto a drug like, say, Fasenra, the overall drug output, because these companies, they give these kind of schemes, 1+3, 1+2. So, the cost gets down, and the overall asthma cost would actually become lesser than that, what they are spending without a biologic. So why does one reserve biologics for so late in management? A cardiologist would never ever think about putting in a stent where it is required. So why does the Indian pulmonologist, why are we so cost sensitive? Why don't we look beyond the TMC era? Why not go beyond that?
So we have always been made to think that biologics are only for the top of the pyramid, the severe asthma patients, and we have always been made to think that it is very costly. We never guide our patients according to the payers, the guidelines. There are many the companies also they are giving schemes, and they have been included in many of the government schemes also, and the private schemes also. So we need to first learn ourselves, and then make our patients also, make them know that they can avail it at a much lower cost with a much lower symptom also. Why do we need to do this? Because now the real world registry data also shows that about 20% of the severe asthmatic patients, they actually achieve remission. They have much lesser exacerbation. Sometimes they don't need to take maintenance OCS even after the first dose of the biologic. They have good control over the symptom, a better lifestyle also. And if we do this forward, they will have a greater work life balance also. So ultimately, they will have a better cost effectiveness in the long run as well. It is
And
also shown that these biologics have also shown that if we start it early, it will help to prevent the airway remodeling also. Therefore, it will prevent the fixed airflow obstruction. The multi-system steroid toxicity can also be avoided. So therefore, we need to make our patients know that this is a very good, safe options to go forward with it.
There is Shamal data now with Fasenra, which tells us that you can actually do away with inhaled steroids in majority of your patients with asthma. So I think that's a huge incentive for Indian patients who don't like inhaled steroids and, who want to get rid of the inhaler. So that is one incentive that I give my patients, that, you want to leave your inhaler, then probably this is one of the medicines that can help you. So biologics are not bad. The way we think about biologics, we really need to change our perspective. The problem is that, the trials with asthma or respiratory diseases, we have never looked at mortality as an endpoint. Any trials, cardiology-based trials, mortality is the endpoint. And what is the message that is given out to the public? Boss, you don't do this, you die. Whereas all data with respiratory diseases, with obstructive lung diseases, especially has been with quality of life, improvement in FEV1, decrease in exacerbation. So now we need to talk more about mortality. Despite the COVID pandemic, people are not scared of dying of respiratory diseases. People are still scared of dying from a cardiac disease. So the way we look at respiratory issues, we really need to rethink the whole situation. And to the younger generation of pulmonologists, when we used to talk about biologics as residents, our professors would sneer, look down upon us. Things are changing now. Biologics are not bad. In the right patient, given at the right time, they would be wonderful drugs. So please remove the stigma from them. Very well said. Avya, the crux of the matter, remissions. Talking about a disease like asthma, if you can have remissions in drugs in diseases like SLE, which is a multi-system disorder, which can affect the kidney, the brain, the heart, the eye, everything. If you can have remissions in a disease like rheumatoid arthritis, which does not spare any body organ, why can you not talk about biologicals and talk about remissions in asthma? It is a doable concept. It is coming up in a big way. How do you see how do you define remissions in 2026, and how do you look at this concept in general? I love it. What's your take on it?
So I'm very intrigued, and I use it a lot when I speak to my pediatric patients. I do a lot of pediatric asthma. So I'm going to talk of remission on two aspects. One, when we look at the pediatric population, and when we look at the adult onset asthma or the pediatric asthma who has progressed as an adult. There's a natural lung development which takes place. The lungs keep growing up till 18 years of age. So if these asthmatics, the toddlers, the young individuals are treated correctly, they will naturally move towards remission. There's enough data to tell that remission occurs when anti-inflammatory reliever therapy is given upfront to asthmatics in childhood, and they achieve remission, and they achieve complete remission in childhood asthma, which means that clinically they are asymptomatic. At the same time, their biomarkers are within normal limits and their spirometry is normal. So this is what we call as complete remission. Now, when we look at the individuals who come more to our OPD, who are the childhood asthmatics who've not been treated correctly or have a so-called relapse of asthma in adulthood, or the adult onset asthmatics, we can achieve remission on two fronts, whether remission is on treatment or remission is off treatment. So remission off treatment in them is hitting them hard, identifying each and every treatable trait. Now, you must have heard Arjun speak about the treatable traits multiple times across the last 2 hours, because it's so very important that if you want to reach that goal and hit the nail on the bullseye and you want to achieve remission in asthma, you can't miss a single treatable trait in these patients. If you leave one factor out, you're not going to achieve remission. That is complete remission with respect to clinical, physiological, and pathological remission. So that's the other aspect of looking at a holistic treatable trait approach. When that is not possible, and you have patients who are the severe asthmatics, the very few, less than 5%, so-called, in my practice, it would be less than 1% of patients, which we call as severe asthmatics, because we hit and we find each and every comorbidity, multimorbidity, and treatable trait. That's the time to tell the patient that we are trying to achieve remission on treatment. That means this is the maximum treatment which we plan to give you for the foreseeable future. We do not plan to escalate your treatment beyond this. We plan to not have exacerbations beyond this, not give you OCS bursts, and probably at the end of 6 months, 12 months, or 18 months, reduce and kick out some of your medication. So that would be a clinical remission on treatment. So this is a conversation we need to have upfront with all our patients, because it's going to instill confidence by telling them that this inhaler may not be lifelong. That's something we need to tell them. And the minute we tell them that this inhaler may not be lifelong, you automatically win them over, because they have been instilled that this is addictive. And here is a pulmonologist who's telling them that this is not addictive and this may not be lifelong. Just do as I say. Let me treat all your treatable traits and follow the correct path. And there is a good possibility you may have complete remission as well.
Sure. And do we have a definition for remission as of now?
Yes, we do have a broad definition for remission where we say that the patient has no symptoms, the FEV1 is stable, there are no exacerbations, and oral corticosteroid has not been used in the last 12 months. So when we look at all these factors over the last 12 months, we can say that the patient is in remission, whether on treatment or off treatment.
Absolutely. So, in COPD, they're talking about disease stabilization concept now. Someone, who would have thought in a progressive disease like COPD, they're talking about disease stabilization. So a disease like asthma, which affects majority of the times younger population, why not give them a fair chance of remission? And that's what every pulmonologist should be talking about. It's a very, very important concept in the years to come, and we must talk more about it. So, Sandhya ma'am, biologics in India are always a very contemporary issue. There are two sets of biologics which are available in our country. Anti-IL-5 biologics, mepolizumab and benralizumab, and then we have the anti-IgE omalizumab. So in India, how does a pulmonologist choose between the two set of biologics that are available?
Before choosing biologics, one has to first consider that it is truly severe asthma. In the sense, we have to look at the adherence part of it. We have to check the technique, which I do at each and every visit. One has to check the technique of the inhaler, and then comorbidities, as you have repeatedly mentioned, that those need to be treated, especially the chronic rhinosinusitis, GERD, obesity. All these are to be treated. And then, in spite of all this, if patient is not under control, then one can consider that probably this is a right candidate for the biologics. Identify the phenotype, like whether it is anti-IgE, or obviously there will be increased Ig levels, positive allergy test, and early onset. Then you consider giving omalizumab. If it is eosinophilic asthma, where eosinophil count is between 150 to 300, then and frequent exacerbator, then either mepolizumab or benralizumab. If type 2 high, then eosinophils are high or FeNO is high, then dupilumab. And there is a practical selection, like if somebody has anti-allergic symptoms, then omalizumab will be the better choice, because there is a strong evidence, it's widely available, it's little cheaper also as compared to the other molecules. And if it is eosinophilic and frequent exacerbation, then there will be either one should use mepolizumab, but it is to be given monthly, and benralizumab every 8 weeks. So the it is better to give benralizumab because the compliance sometimes could be better because it is used every 8 weeks. And if there are multiple comorbidities like nasal polyposis, dermatitis, then dupilumab works better, especially in type 2 disease. Then again, while choosing, cost is a major constraint as far as Indians are concerned. So omalizumab somewhere 20 to 30,000 per month. Mepolizumab is almost 80 to 1 lakh per month. Benralizumab is 1 to 1.5 lakh per month. And dupilumab is again 1 to 1.5 lakh. But the pharma companies have some schemes, and especially in central government individuals, again it is easily it is provided, those who are covered under CGHS. Some of the Mediclaim people also, it is covered. So considering cost and everything, one has to choose which one is better. And if I to give a quick algorithm, then first of all, one has to check eosinophils and IgE. Allergic dominant, I would prefer omalizumab. If eosinophilic dominant, IL-5 or mixed, then IL-5 like benralizumab, mopolizumab. And if the mixed and comorbidities are there, then dupilumab. But there are certain things where one should not use this, where there is a poor adherence. If the diagnosis is not correct, so I have to consider first of all that my diagnosis is asthma. There are no exacerbations and there is mild asthma. These are the things where one should not go for any biologics.
So biologics are for true severe asthma. Dupilumab, unfortunately, they're not bringing to India. Phase 3 trials done, and they've said that we are not bringing it to India. Let's hope that tezepelumab comes to our country. But as of now, and there are chances that it might, but as of now, the choice, as you very rightly said, is between omalizumab and between Mepo and Benra. Between mepolizumab and benralizumab, again, there is no head-on data. There is no head-to-head trials. You cannot compare apples with oranges, and the companies would never let that be done. So both schools of thought exist. People who fail on benralizumab do well on mepolizumab. People who fail on mepolizumab do well on benralizumab. Why that happens is still not seen. So in adult onset asthma, which is Th2 eosinophilic, one would probably choose the anti-IL-5 therapy. Very important marker, which is often missed out when we are choosing biologics, is mucus impaction on CT scans. And this is something that is coming out in a big way, that if on a CT chest you see mucus impaction, then this is a patient who is going to respond very well to anti-IL-5 therapy, especially benralizumab. So that is something to look forward to. And also, the cutoff of eosinophil counts is changing in a big way. It used to be 300 for biologics, brought down to 150, brought down to 100. There is now data which is coming up, which now tells us that you actually need not look at eosinophil levels before starting anti-eosinophil therapy. The one factor which would tell you whether or not a biologic is going to be effective is if the patient is steroid responsive. So by definition, a Th2 asthma is steroid responsive. So the largest centers which actually deal with asthma now, King's College London, which has the largest series of patients with anti-IL-5 therapy on biologics, they actually don't even look at the eosinophil counts now. If there is a history of response to steroids, then majority of these patients will respond to biological therapy. Obviously, in India, where everything is so tight regulated and everything is so expensive, you cannot overlook the guidelines. And that's a point that ma'am has very well highlighted, that because these drugs are expensive in India, if you give an expensive drug to a patient and it doesn't work, the patient is never going to come back to you. You get a bad Google review and he's going to tell 20 different patients that don't go to this guy, So be very careful when you are using biologics in our country. Fantastic drug for the correct people, terrible drugs for the wrong people. So you really need to be, very careful about it. So, Gaurav, coming to you, pregnancy with asthma is again a very contemporary issue. GINA guidelines have a separate chapter on it now, and this is a question that has been coming up in the chat box very frequently. Very quickly, how do you manage an overview of management of asthma in a pregnant woman?
Thank you for the question. Actually, pregnancy is a condition where we can have primary prevention of asthma in the progeny. So I briefly review the patient clinically as well as by history. I generally rule out the other causes of breathlessness like anemia, physiologic dyspnea of pregnancy, eclampsia, severe hypertension, or pulmonary embolism, pulmonary artery hypertension. If these causes are ruled out, then I see the basic clinical history as well as primary investigations. All the investigations that can be done in pre-pregnant level status should be done in pregnancy also, other than bronchial percussion test. So patient should be screened for asthma by PEFR as well as spirometry. As we know, there is no role of routine chest X-ray, so X-ray should not be done. After this, patient should be screened for high risk exacerbation factors like obesity, GERD, rhinitis, patients who are multipara or age more than 35 or history of severe exacerbation are patients who will definitely have some exacerbation in the pregnancy. Luckily, 33% of the patients do not have any exacerbations, 33% remain similar to pre-pregnant levels, and 33% will have asthma exacerbation. So 66% of the patients generally do not pose any problem. The remaining 33% we have to manage. The crux of the treatment is the treatment which we are giving pre-pregnancy should be continued in the pregnancy. ICS LABA combination is very safe. Even theophylline and Montelukast is also safe, so can be continued if patient is having rhinitis symptoms and patient is stable on these drugs should be continued. High dose ICS plus LABA is also safe. Even tiotropium can be given in pregnancy if patient is on 3 drugs pre-pregnancy. Also, we have to keep in mind that there are several food general things that are marketed like pufa, fish oil, vitamin D, but these are not have been proved conclusively that these are helpful in decreasing the asthma levels or asthma symptoms. So should not be used alone or should not be recommended. Pregnancy should be we should advise for vaginal delivery as it decreases the chances of asthma in progeny. We should also encourage breastfeeding, but this does not goes to decreasing the asthma in the progeny. Only it decreases the wheezing episodes. So common belief that breastfeeding will decrease the asthma in childhood is not true. Only it decreases the wheezing episodes. These are the things we can get in pregnancy. Other routine tests can be done and all the drugs can be continued.
I think that's a point very well made. And I think the most important point is that if a woman is pregnant and they, have asthma, it is a very common misconception, at least in my part of the country, that inhalers are thought to be unsafe and females would stop using these inhalers, and this leads to exacerbations. So, there's a general rule of 1/3 that you use in asthma. 1/3 asthma remains same, 1/3 becomes worse, 1/3 improves with pregnancy. And you really don't know, it's like Russian roulette, in which category that woman would come, you don't know. So it's always better to continue the inhaler therapy during pregnancy. Don't shift to any high-fangled new drugs during pregnancy. Don't start a biologic during pregnancy. If a patient has been on, drugs where the asthma is controlled, continue using them. But because, even if when you start a new drug in pregnancy and if there is an untoward complication, if there is fetal compromise or maternal compromise, then that drug gets blamed. So don't do anything fancy or anything too heroic when the woman is pregnant. But the most important message to give across always is to continue their inhalers. That is very important, right? And very well summarized, Gaurav. Atul,
Arjun, can I add a point there for pregnancy?
please.
Just a point that we need to stress more on influenza vaccination in pregnancy. That's very important. And in our asthmatics, it becomes even more important. So that's something we need to tell our pregnant asthmatics that please go back to your gynecologist and ensure that they advise you not just the TT, but as well as the influenza vaccination.
It is very important.
One important point, Arjun, it is most of the gynecologists who ask the patients to stop inhale corticosteroids and not the patient. So I think we have to educate our gynecologists that these drugs are very safe in pregnancy.
Yes,
I think, ma'am, anyone in the world would be able to do that. But yes, one can hope and pray that we can ever do that. But yeah, that's a very, very long shot. Yeah. So Atul, coming to you. Indian patients are very fond of home nebulizers. You give them an inhaler and they flip out that this is really bad, but they would be very happy to nebulize 10 times a day. So home nebulization is coming up in a big way. We now have single nebulization triple therapy. We have ICS Lama Laba, Ultra Laba Lama, all available in nebulized form in our country. So, what is the rational way of nebulizing, home nebulization therapy in India?
So when it's coming to asthmatics, the most common scenario where I use home nebulization is basically for small children who are less than 5 years. Many of the parents, firstly, they have a proper difficulty in using the inhaler properly with a spacer. Secondly, the parents always have a stigma towards inhaler, whether he will have to continue it lifelong. And nebulization is something which they prefer. And as you know, our patients are always ready to use nebulizations. So I use it in younger age group, in the middle age or the adolescent age group or such age group, I always prefer to use inhalers. And in older age group, who especially in patients who have some neurological issues, who have Parkinson's, coordination issues, etc. And obviously, it is finally what they say is a shared decision making. What they say. So, firstly, finally, it's the patient preference. But especially if it's an old age bedridden patient who has some coordination issues, those are my clear cut indications. And obviously, in children, because parents mostly prefer nebulization, and especially if it is less than 5 years. We put them on home nebulization so that it's easier to use for the parents as well, and there is some amount of delivery that is happening. Sometimes with MDI, even if we are using with spacers in kids, it might not give us the desired results.
So I think the onus is not to give it to everyone and tell them that this actually there's a lot of drug that goes inside with nebulization. It can have its own set of side effects, and inhalers are safe, right? So I'm running out of time. I have last 3 minutes left. So Shreyami, we talk about all contemporary therapies in asthma, and we limit our discussion always to biologics. Is there anything coming above biologics in the management of asthma?
So there are many upstream alarmin pathway blockers that are coming up. One to we also now know is the anti-TSLP, the tezepelumab, which
Hmm.
we hope comes to India soon. Then one of the questions was about itepekimab. It's a IL-33 blocker that's also in pipeline. There are small oral inhibitors that are also in pipeline, which are oral BTK blockers or JAK2-STAT pathway blockers. Then there is fevipiprant, that is a prostaglandin D2 blocker. It's the receptor is the one where IL-4, 5, and 13 works. So it's also an upstream alarmin blocker. And then there are good old the macrolide therapy, the azithromycin, that have shown benefit in selected non-eosinophilic, the low T2 variety, or the mixed phenotype also in some ones. And then we have the allergen immunotherapy that we can consider for the children and the young adults. But we have to see the history for the clinical significant history and sensitization to the aeroallergens. The most common of them is the house dust mite and the pollens, which is specific to each areas of the country. It is available in two forms. One is the subcutaneous form, another is the sublingual form. The most commonly used is the subcutaneous that we also do in our setup. So subcutaneous involves that is the administration of extracts or progressively increasing higher dose over usually a period of 3 to 5 years. But before considering this, we should always rule out if there is a dermatographism or there is ongoing severe asthma. And we should always see the FEV1. If the patient is adult and the FEV1 is more than 70% in a stable asthma, then we can provide. And in children, it's more than 80%. Other than that, we have read about the bronchial thermoplasty. And then there are digital health devices, the smart inhalers, and we should never ever forget about the treatable traits algorithm.
So lots of tongue twisters coming in asthma. The younger generation needs to know about them. Oldies like us can very well trust you guys to remember that for us. So we had close to 2,000 logins today. And with 2,000 logins, the questions obviously would skyrocket to more than 200. And I'm very sorry, I could not obviously take all these questions because I would be sitting till, all our panelists would be sitting till 10:30 a.m. in the morning if all the questions that I have got, I would answer. So I've chosen the questions that were being asked more often and questions that had some clinical relevance to them. I apologize profusely if your question has not been asked. Dr. Avya Bansal has very generously, agreed to answer all these questions. If you ask them personally over a DM, Avya is a man, of his word, and he'll keep his promise, I believe. So I'm just kidding. Thank you, all the panelists. Thanks, Avya, for that fantastic talk. You summed up GINA 2026 so well. And man, to do that in one night is really commendable. Please send me that presentation so that I can read it and I can brag about it to my postgraduate students tomorrow and, kind of tell them that, you don't study and see your boss knows the latest guidelines overnight. Thank you, Sandhya ma'am, despite being in pain for being with us today. And Gaurav, Atul, Shreyami, young minds are always welcome. And you always bring a whiff of fresh air to the thoughts that we have discussed. Thanks all of you for being here. Thank you, Amita ma'am and the team at ICS for doing this every week relentlessly and for improving the pulmonary landscape in our country, for making all of us more knowledgeable, more intelligent. Thanks to Lupin and everyone who's provided us technical support today. It's always a pleasure to interact with the pulmonology fraternity in our country. We are growing in a fantastic way. We are growing exponentially. And I always tell my postgraduate students that, we are the new age cardiologists. Our branch is becoming really hot, and the onus is on us to make it hotter, right? So with that, I thank all of you for being with us here today. I thank my panelists and the ICS for giving us this opportunity for interacting with each other tonight. With that, good night, everyone. Hope to
Thank
see you very
you.
soon
Good
with
night.
another ICS webinar. Thank you. Good night.
Good night.
Thank you.
Thank
Good
you.
night.
Thank you,
And
everyone.
thank you, Arjun, for
Good
an
night.
excellent moderation and
Yes.
ensuring we were on our toes and you passed the message and delivered the message to all of us beautifully. So thank you so much, Arjun. Thank you.
Thank you. Good night.
Good night.
Good
Bye.
night. Bye bye.
Thank you so much, everyone, for joining today's session. So, with that, I'm closing this session. Thank you so much.